Good afternoon, everybody. My name is Dr. Ibrahim. I'm one of the stroke medicine trainees in Salford Royal Hospital, and I'm going to present case presentation number 4. Our patient is 51 years old, male. He's generally independent with an MRS score of 0, lives with his wife, never smoked, and he drinks alcohol 2 to 4 times a month. He has background history of type 2 diabetes diagnosed in 2021, hypertrophic cardiomyopathy in 2020, and that was diagnosed with cardiac MRI. Also, he has history of high cholesterol, sensorineural deafness, and he uses hearing aids, with a history of chronic rhinitis, appendectomy, adenoidectomy, anxiety, and hypotension. His regular medications include bisoprolol, metformin, atorvastatin, and he's triple vaccinated against COVID with Pfizer vaccines with no known drug allergies. Firstly, he was admitted to us in November 2021 with difficulty in communication, reduced oral intake, and confusion. And on examining him, his GCS was 14 out of 15, otherwise normal observations, and glucose of 5.1. His NHS score was 5 for inability to recognize his age and the month of the year, with severe dysphagia and right upper limb drift. Also, his comprehension was severely affected and can only follow one-step commands with frequent paraphasia and neologism and impaired namings. Examination of other systems otherwise unremarkable. His weight was 44 kg, height 160 centimeters, chest X-ray, NAD, and ECG showed sinus rhythm with left ventricular hypertrophy and strain pattern. Bloods in general were unremarkable, apart from triglycerides of 2.8 and lactate of 2.82. And this is his ECG, which shows the signs of left ventricular hypertrophy with a strain pattern, and it was sinus rhythm. When we did CT for him, it's showed here in the blue circle the features of the acute left temporoparietal infarct, but at the same time there is symmetrical bilateral extensive calcification in both basal ganglia, and also there is bilateral symmetrical calcification in the corona radiata area. This is a FLAIR MRI sequence which showed calcification on both sides, and it again confirmed the acute ischemic stroke on the left temporoparietal lobe. This is the official CT and MRI report, which is an acute left temporoparietal infarction in the left MCA territory with bilateral symmetrical extensive calcification in both thalami, globus pallidi, and corona radiata, and no stenosis or dissection in the internal carotid arteries. And suddenly at night, he developed focal seizure with reduced level of consciousness, blood pressure of 70/47, oxygen saturation of 100, heart rate 83, with low BH, high lactate, and basal excess of -18. We resuscitated him with IV fluids. He remains stable after that. And we repeated his CT, which showed stable appearance. We admitted him to our stroke unit, started him on aspirin, 300 mg, levetiracetam for the seizure. Also, we got dietitian, occupational therapist, physiotherapist, speech and language therapist input, and we asked for neurology opinion. After we stabilized him, we discharged him home with some pending blood tests. Unfortunately, he was presented again in January of this year with confusion and ataxia, irrelevant non-sensible speech, poor comprehension, neologism, staring, no eye contact, and strange behavior. And he wanted to discharge himself, but we deemed him as lack of capacity after discussion with his wife. His GCS on the second admission was 14 out of 15. Very raised troponins, like 600 and then 500. Lactate was 4.1 with pH 7.27. And his repeat CT showed new right temporoparietal infarct and still showed the bilateral extensive calcification, as mentioned before, and surprisingly, lack of the expected infarct evolution normally seen in the left-sided changes. This is his second CT on the second admission, which again showed symmetrical bilateral calcifications. He was seen by cardiologist for raised troponin, but as there is no dynamic troponins, he wasn't treated as an acute coronary syndrome. We start treating him with acyclovir for curing encephalitis. Lumbar puncture was very challenging, but after that it was deemed not indicated. But we sent blood for meningococcal, pneumococcal, and viral screen, which all came back as negative, and his blood for serum copper and ceruloplasmin were normal, as well as thyroid function test, and we asked for EEG. So at this point, we considered three differential diagnoses for symmetrical intracerebral calcifications, which are Fahren's disease, Milas syndrome, and parathyroid axis abnormality. And when we go back to our patient, he has features of encephalopathy, lactic acidosis, short stature, stroke and seizure, myopathy, sensory neural deafness, hypertrophic cardiomyopathy, diabetes, and anemia. Genetic tests are back, which showed there is a mutation in the 32431G mitochondrial DNA mutation, which is positive for Milas syndrome, with a heteroplasmy level of 34%. And the EEG report also is back, which showed slow wave activity of 5 to 6 Hz, suggestive of moderate degree of encephalopathy. So he was confirmed to have a Milas syndrome, which is a rare mitochondrial inherited disorder characterized by mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. It's usually inherited from the female parent, and the male-to-male incidence is 1:1. Males in general, they do not pass the affected mitochondria into their offsprings because the sperm path that contain male mitochondria is not included in the fertilized egg. So mitochondrial disease in children in general is characterized by encephalopathy, stroke, seizure regressions, deafness, cardiomyopathy, diabetes, renal disease, anemia, neuropathy, blindness, hormone deficiencies, liver failure, enteropathy, and myopathy. And the pathogenic mechanism of mitochondrial angiopathy in Milas is possibly related to nitric oxide depletion. So the management of Milas, in general, there is no cure, and usually it's a progressive and fatal disease. Usually we treat the affected systems. We can use coenzyme Q10, nicotinamide, and riboflavin, but nowadays L-arginine can be used and it can reduce brain damage, especially in the acute situations. And the most important thing is the genetic counseling. Thank you very much for listening.